All right, so we are back on, folks. Thank you so much for joining us today. This is Jonathan Ruthier, Executive Director for CSNI, the Association for the Area Agencies in New Hampshire. And we're really excited to have you all join us today for our webinar on neuropsychological evaluations for adults with disabilities. Our guest today is Dr. Stefanie Griffin, who is a neuropsychologist licensed here in the state of New Hampshire. Many of you are familiar with Dr. Griffin's work. And she comes to us having completed her training out in the Midwest, starting in Nebraska and then going on to Michigan and then Iowa. So she certainly is familiar with the cold weather that we've got here right now. And we're really lucky to have her here in the state of New Hampshire. So just a few things before we get started to help you as you experience today's webinar. First off, we are recording the webinar. And after the show, we'll be condensing the sort of the initial part of the recording down, but we'll be posting it on the CSNI website, which is csni.org. And you can find that under the events tab on our website. There's a link there for recorded webinars. We're also going to be sending a survey out to all of you after today's webinar, so you can let us know your thoughts and any ideas for future webinars. And lastly, I just wanted to point out that you're all muted when you signed in to the webinar today so that we can just sort of focus on delivering content. But you may have questions as we go along. The way to pose a question is to just hover your mouse over the bottom of your screen. There should be a Q&A button right there. And so all you do is click on the Q&A button. You can type your question in and hit send. And we will monitor questions here throughout the webinar and try to get to all of them before the end of today's session. And again, if we don't get to all of them, we will try to respond to everybody with an email for any questions that were not answered. We will hold all of the questions until the formal presentation is done, but we're going to try to leave 10 or 15 minutes to try to get to all those questions. So I think without any further ado, I'm going to hand off to Dr. Griffin, and we are going to get the show started here. So Dr. Griffin, thank you so much for joining us today.
Hi, I'm happy to be here. So I was asked to talk about neuropsychological evaluation. I am an adult neuropsychologist, so the presentation will be geared more toward adult neuropsychology. Oftentimes, individuals train separately as pediatric neuropsychologists, and there are some aspects of the evaluation that are a little bit different, but generally speaking, the things that I'll be talking about today apply to both adult and child neuropsychological evaluation. So I wanted to start off by just explaining a little bit about how neuropsychology differs from psychology in general and how neuropsychologists are different from other clinical psychologists. And then I'll talk a little bit about what an evaluation is like, what people might expect as part of an evaluation, and I'll wrap up by talking a little bit about referral questions and how people can optimize referral questions, because that's something that can really be important in terms of having a good evaluation completed. So neuropsychology is the scientific study and clinical evaluation of brain-behavior relationships. And it involves measuring cognitive abilities, mood, behavior, and linking these to structure and function of the brain. Neuropsychologists are professionals within the field of psychology, so it's a subspecialty within psychology that includes specialized expertise in the applied science of brain behavior relationships. Neuropsychologists engage in assessment, diagnosis, treatment, and/or rehabilitation of patients across the lifespan, and that includes individuals who may have neurologic, medical, neurodevelopmental, psychiatric disorders, or other cognitive or learning disorders. So how are neuropsychologists different from other psychologists? As I said, neuropsychology is a subspecialty within the field of psychology. So neuropsychologists generally complete doctoral training in clinical psychology. So that usually involves either a PhD or PsyD program. But within the doctoral program, neuropsychologists take specialized coursework in brain and behavior relationships. Like all clinical psychologists, neuropsychologists complete a year of pre-doctoral internship training, but neuropsychology internships are recommended, so internships in which individuals are focused on neuropsychological assessment and treatment are recommended for individuals who are looking to practice in neuropsychology. And then the final and probably one of the more important components of neuropsychological training involves a 2-year postdoctoral training experience in which individuals really subspecialize after obtaining their degree. So I'm spending a lot of time talking about training in part because it's a little bit difficult at times for consumers to know the difference between the different professions and to understand what they should be looking for when they're looking for someone to perform evaluations. And one of the things that makes it particularly complicated is that states in general do not have any separate licensure for neuropsychologists. For example, in the state of New Hampshire, as is the case in most states in the United States, individuals are licensed as clinical psychologists. And there's no way of distinguishing whether someone has training to conduct neuropsychological evaluations or not, just looking at their licensure. So it's important to understand what training is necessary. And when you're, as a consumer or potential consumer, unless you're working with someone who's well known and recommended to you, it's important to understand that you should be looking at their website, reviewing their resume, talking to the provider in advance to find out what qualifies this clinical psychologist to perform neuropsychological evaluations. There are some organizations that offer board certification in clinical neuropsychology. And so that's a process, and it's a voluntary process. So not all neuropsychologists do this. It's a process by which people have their credentials and their training reviewed by a national agency. They complete written examinations and an oral examination. And upon passing all of those steps, they're board certified. So one example of that is the American Academy of Professional Psychology, which does issue board certification in clinical neuropsychology. So if you see someone who has the credentials ABPP-CN after their name, you can be quite confident that that person has the necessary training and expertise.
Just a quick break here to just come back in, and for those who are just joining us, to let you know that if you want to submit a question, the easiest way to do that is to just hover your mouse over the bottom of your screen, click on the Q&A button, and it'll give you a little dialog box to be able to type a question in, hit send, and we'll try to get to all of those questions at the end of today's webinar. Again, thank you for joining us. You're on the CSNI webinar series, Neuropsychological Evaluations with Dr. Stefanie Griffin.
So moving on to the next slide. Who do neuropsychologists see? So neuropsychologists see a wide range of different individuals. As I said, some neuropsychologists specialize in either pediatric or adult neuropsychology, but individuals who have a history of concussion or more severe traumatic brain injury, stroke, dementia, attentional disorders, learning or academic problems, psychiatric conditions, medical conditions that might impact thinking abilities, such as seizures, intellectual or developmental disabilities, substance use disorders, or individuals who have concerns about their cognitive functioning. For example, someone who may feel that their memory is changing, for whom it's really not understood why this is happening. Who can make a referral for a neuropsychological evaluation? The answer to that is most people can do so. So oftentimes primary care physicians, neurologists, psychiatrists, vocational rehabilitation counselors, the individual's treatment team from the area agency, for example, the school team if the individual is being supported through an IEP. Individuals may be able to make self-referrals as well. There are times, depending on who's funding the evaluation, particularly if insurance is paying, there may be a requirement that a formal referral come from a physician for billing purposes. But that can happen in such a way that if the individual has concerns, they may speak with their provider and explain the concerns and ask for a referral to happen. I want to talk a little bit about the process of the evaluation. So this is something I think that can be most surprising to individuals, is that neuropsychological evaluation is really unlike any other doctor appointment that you have. So you never go see a doctor for 6 hours. I don't know of any other provider where that happens. And oftentimes when we schedule individuals for evaluations, either the individual or the treatment team or family may say, oh, that there's no way that person's going to sit for 6 hours and participate in an evaluation. And that is a valid concern. What we typically do in this office, and many neuropsychologists do, is we try anyway. And there are a number of reasons for that. It is helpful, especially for individuals who may have issues with fatigue or with behavioral difficulties. It can be very helpful to actually spend a good amount of time with someone. If evaluations were broken up into 1 to 2 hour sessions, we may not actually be able to observe the behaviors of concern. And if we're able to spend the entire day with someone and maybe push limits a little bit, we're more likely to actually see the behaviors of concern. So in this office, in my office and in many, we often attempt to perform the entire evaluation over the course of the day, which can often take up to 6 hours, understanding that we may take breaks and understanding that it may be the case that individuals may not be able to complete it and we may need to reschedule for a return. But I very often hear my administrative assistant who does the scheduling very often hears concerns about the 6 hour evaluation. And in I would say 9 cases out of 10 or even more, despite concerns, the individual is able to participate and complete the evaluation in one session. The setting typically takes place in an office, ideally in a setting that is free of distractions. There are some neuropsychologists who are hospital-based, and they may be seeing people with acute injuries like stroke or brain injury, and our equipment is portable. It can move and can be done at bedside if needed, but it's best that it happens in an office where things are quiet and the environment can be controlled. The content of the evaluation is pretty straightforward. It's all paper and pencil, answering questions verbally. There are some computerized measures, but the individual does not have to have any expertise in computers to perform them. There are stimuli like blocks that the individual may have to put together. I always tell people at the beginning of the appointment that I'm not going to poke or prod you at all, so I'm not that kind of doctor. It's all hands off and we're sitting across the table from each other working together. And it's very common for people to have anxiety about the neuropsychological evaluation. It's a long appointment. People if they haven't done it before, they really don't know what to expect and can't imagine spending 6 hours with a doctor. The idea of having memory tested is very intimidating for individuals. But what I hear more often than not is it wasn't as bad as I thought it would be. And I try to typically encourage people that it's okay to feel nervous and anxious. That's typical. So I want to talk next about the components of the evaluation. So the evaluation starts with thorough clinical interview. And I'll talk a little bit more about what that involves in a minute, but it's very helpful for the interview to take place not only with the individual being assessed, but also with collaterals. And the collaterals may vary. So I know that I'm speaking mostly with individuals from area agencies or family members here. And so oftentimes having a family member participate, having a case manager or someone who is a day program support staff or a residential provider, and in fact having as many of those people as possible participate in the interview is very helpful. The goal of the interview is not to test memory for the client. The goal of the interview is to get as much information as possible in order to have a good context and understanding in which to interpret the test results. Sometimes it can be challenging for people to participate in a clinical interview and have team members, for example, answer questions about them. And in those cases, we at times will schedule a phone interview or a separate interview at a different time, as long as the individual being assessed is comfortable with that. So we can be flexible about how that happens. But again, having as much input as possible at the beginning of the evaluation is extremely helpful. The formal testing is really what constitutes the bulk of the evaluation. The interview typically takes somewhere between a half an hour and an hour and a half, depending on many things. But it's at the beginning typically. And then the neuropsychologist works alone with the client during evaluation. There are some very rare cases where if an individual is considered extremely high risk, someone may be allowed to sit in the office, but the preferred arrangement is to have the individual working alone with the provider, because there are a number of reasons for that. But one is that it's already intimidating to have your cognitive functioning evaluated, and having someone else sitting and watching you have your cognitive functioning evaluated is even more intimidating. Some neuropsychologists use a person called a psychometrician. These are individuals who are typically have a bachelor's or sometimes a master's degree and are specifically trained in test administration. So that is their job. The neuropsychologist typically conducts an interview and does the interpretation and report writing. It is accepted practice in the field to use psychometricians. Some neuropsychologists do, some don't. I tend to do my evaluations, the testing myself. And then the pieces of the evaluation that happen after the client leaves include interpretation and report writing. And this involves interpreting and integrating the results, the history, the behavior seen during evaluation, records, and I'll talk more about interpretation in a little bit. Most neuropsychologists schedule feedback sessions with the individual who has been evaluated and other members of the treatment team, if there is a team. That's typically scheduled at a later date, and it's an opportunity to sit down, review the report together, talk about recommendations, and ask questions. There are times when the treatment team will ask me, does the individual who has been evaluated need to be at the feedback session? And I always leave that up to the team and the individual or his or her guardian to make a decision. There are times when it's actually too difficult, too emotionally overwhelming, too challenging for someone to sit in a session with a lot of other people from the team and talk about test results. So there are different ways that the feedback can be arranged depending on the person's needs. Yep. All right. So the clinical interview, I just want to talk a little bit more about that. The purpose of the interview is to verify and inform. So very often the referral source has sent records to the neuropsychologist in advance, and it's extremely helpful to have a full set of records, any prior psychological or neuropsychological testing, any psychiatry treatment notes, for people being referred through area agencies, the service agreement, if there is any history of risk assessment, any behavior support plans, all of that information is really helpful for the neuropsychologist to actually have in advance of the evaluation. Because in order to ask good questions during the interview, the neuropsychologist really has to have some understanding what they need to ask about. So the interview can be used to help verify the information in the records, but also to inform. And the interview is typically very comprehensive. And so we ask about really birth to present day and ask a lot of questions, often starting out with the primary complaints. You know, what is the concern? Why is this person here? What are the person's concerns? What are the concerns of the individuals who are working with that person? Getting an understanding of the neuropsychological history. Are there problems with memory or problem solving? When did they start? Are they getting worse? Are they constant? Are they episodic? Understanding the person's complete medical history, because there are many medical problems that can contribute to cognitive difficulties. Obstructive sleep apnea being a good example of one of these. And so the neuropsychologist will take a comprehensive medical history, to help understand any other history of neurologic difficulties like seizures, prior head injuries, as well as a full medication history. It's always helpful when someone comes to an evaluation if they have a written copy of their current medications and doses. Some medications can have cognitive side effects that have implications for the test results, and it's important for the neuropsychologist to know that. A good understanding of the developmental history to help identify whether the individual had any pre or perinatal complications, whether there were delays in development, understanding the individual's family of origin history to help understand family dynamics that may continue to impact the person, to help understand whether there was any history of trauma that may continue to impact the individual, to understand family genetic risk factors for specific conditions, and a good educational and occupational history to understand what the person's baseline level of functioning may be, how they did in school, whether they had supports, whether, how far they went in school, whether there were emotional or behavioral challenges in school, as well as thorough occupational history. So those are all aspects of the person's history that will be addressed during interview. So some may wonder, what is the difference between doing a neuropsychological evaluation and testing and simply spending time talking to the person and watching them? So the goal of neuropsychological evaluation is to provide an objective assessment of thinking abilities. And so there are a number of ways that this is accomplished. The primary means is through standardization of tests. So there's a whole set of tests that neuropsychologists use, and there is some variability. So one neuropsychologist may have some subset of tests that they prefer to use, and it may be slightly different from those that another neuropsychologist uses. But if a neuropsychologist is using the same test as another neuropsychologist, the goal is standardization, so that the test is all of the stimulus materials, anything that the client is looking at or manipulating, any of the instructions about how to complete the test, and all of the scoring of the tests are all the same. So if I'm seeing someone in my office in Dover and someone else is testing someone with the same instrument in an office in California, or if I see someone now and 2 years from now, another provider sees that individual, because the test materials are standardized, we can have increased confidence that the results from those tests are reliable, that they're meaningful, and that we can compare them to each other, as opposed to having more kind of subjective information about the individual. The other piece that is really important about neuropsychological assessment is that the results from the evaluation are referenced to age and education corrected normative data. So what I mean by that is, for example, I may administer a block design test to a client. So a test where the person has to put a series of blocks together to make them look like a design I've given them. And the person may end up with a score of 42 on that test. That number, 42, means absolutely nothing to anyone, really, unless we understand how that person should be performing on the test. And how the person should be performing depends on many things, most importantly, their age and their education, because performances on cognitive measures change with age, and they are different in different educational groups as well. So with all of the tests that are administered, each of the raw scores, which are just the kind of total score on the test, is converted into a standardized score, where because these tests have been administered to large numbers of people across the country, and we have normative data, so we understand what the average score should be and what the range of normal is on a test, we can then take all of the individual scores and compare those and put all of the scores from the different tests on the same measure, on the same scale. And that way we're able to understand strengths and weaknesses, as well as whether the person's performances are as they should be or not. So these features contribute to two key pieces that we're looking at with neuropsychological testing, which is reliability, meaning that it's consistent across time and examiners, as well as another important component, which is validity, which is to say that if I'm giving a test that I say is a memory test, we can have confidence that we know that it's actually testing memory and not something else. And that's based on the research and design that has gone into development of that measure. Having said all of that about the importance of standardized testing in neuropsychological evaluation, behavioral observation is also a very important component of the assessment. And so while all of these tests are being administered, the neuropsychologist is also very carefully watching the client, watching what's happening, watching how they approach the tests, listening to how they speak, looking at their level of engagement. All of those things are extremely important and are integrated into the results. In terms of domains of assessment, I'll talk a little bit about all of these. I'll try to be fairly brief, but most neuropsychological evaluations will incorporate assessment of some piece of all of the following: orientation, sensory, perceptual, or motor, intellectual functioning, attention and concentration, processing speed, learning and memory, speech and language, visuospatial skills, executive functions, academic skills, personality and psychological functioning, and effort. They're depending on the referral question and the presenting concerns. There may be more focus in some areas than others in any given evaluation. So I'll run through what I mean by these terms. Orientation, I think most people are familiar with this. It's an understanding of how aware and alert are individuals to their surroundings. So can people tell you who they are, where they are, what the date is, why they're here in your office? This is something that for the most part people are able to answer accurately, but in some conditions orientation is affected. Some testing of sensory, perceptual, or motor function is often completed as part of an evaluation. This may involve assessment of things like visual processing, hearing, tactile, which is a sense of touch. In some individuals, there may be questions about neglect, which may involve failure to attend to information in either one visual field or another, for example. Testing of manual speed and coordination is often takes place. Okay. The test that I'm showing here in this picture is a test of manual coordination. So the individual has some metal pegs that they are asked to place in the board, and the speed with which they do that is timed. So it's a very simple, basic motor coordination test. Oftentimes people are familiar with assessment of intellect. So people, probably the most common type of test that people who come to see me know about is the IQ test. The IQ test is really or I should say the IQ number, so a full scale IQ number, is really an average of a person's performances on a number of different subtests. And as such, the full-scale IQ score may or may not really be meaningful for that individual. If someone has a lot of variability in their subtest scores, then averaging all of these variable scores together really doesn't tell us much about what they can and can't do. And so as a neuropsychologist, what I'm most interested in is really the subcomponents of the IQ score. Which include things like verbal comprehension, so verbal skills, perceptual skills, which are nonverbal skills, working memory, which is attention, and processing speed. And I'll talk more about those. Attention and concentration involves a wide range of capacities. It includes auditory and visual attention, and is often assessed using tests of working memory, which is the ability to hold on to information in your mind. So for example, say someone gives you their phone number and you can't write it down right away. You have to kind of go grab a piece of paper. You're using working memory to hold on to that number in your head. Sustained attention refers to the ability to stay focused over a long period of time. Selective attention refers to the ability to screen out things that aren't important to focus on and pay attention to what's important. And then divided attention refers to the ability to move back and forth between different things that are important to focus on. And these are usually assessed to some extent in the course of the evaluation. The image that I have here is an example of one test of sustained attention, where the person is asked to, on the computer, press the space bar every time they see a letter except the letter X. The computer is able to measure how quickly they respond, whether or not they miss any of the targets, whether they're hitting X's when they shouldn't, which is a measure of impulse control, another function that I'll talk about. So that is one fairly common measure of sustained attention. Processing speed is another domain that is assessed. So processing speed typically includes both verbal and nonverbal processing. So how quickly do you take in information from others or from the environment, and how quickly can you respond? And that's a very important function because if individuals have reduced processing speed, it can affect all other areas of functioning. And so we assess both input and output. On the screen, I have a sample of a type of test that is commonly given to assess basic processing speed. Neuropsychologists try not to share their tests with the world for many reasons, in part because we don't want people practicing them before they come in for evaluations, because if you have practice with the test, you get better at it, and then we really aren't measuring what you can and can't do. But this is actually an open access test that is available freely on the internet. So this is a kind of a little bit of a changed version of the trail making test, where the person is asked simply to connect the numbers as quickly as possible, and their time is, they are timed. The test itself looks different than this and is longer, but it's a basic measure of simple processing speed. And then we also include measures of more complex processing speed to see how, when we add demands and challenges, does that make things more difficult or not. Assessment of learning and memory is also an important component, and we try to assess the range of memory functions. Remote memory being how well does someone remember things from their history, from when they were children and early in their life. Recent memory being things that happened more recently. We assess verbal and nonverbal learning and memory because some individuals have strengths in certain areas, and it can be helpful to understand those. We also assess encoding, which is similar to learning. So how well do you do with getting information in when it's presented to you, as well as retention, which refers to how well do you do with holding on to that material over time. And we also look at recognition memory. So even if you're not able to independently retrieve information, if I give you some cues, does that help? So we're trying to understand, did the information actually get in to begin with? And if we help a little bit, are you able to pull it out? So there are many different types of memory tests. One common one involves reading a list of words, reading that repeatedly, looking at how well the person learns over time with repetition, and assessing recall for that material shortly afterwards and after a longer delay. Language is an area of function that is assessed in a variety of domains, includes assessment of word finding, fluency, comprehension, both auditory and reading, writing, repetition, word knowledge. I'm going to move through these a little bit more quickly to make sure I'm on time. So I won't explain all of the test pictures that I have here. Visuospatial abilities are also assessed, and that refers to how your brain makes sense of what you see in the world. So tests where you're asked to look at items and figure out what's missing, or put blocks together to make designs, are tests of visuospatial function. Executive functions involve a whole range of abilities. Executive functions are the most complex set of cognitive abilities that humans have. And they are evaluated through tests of problem solving, impulse control, set shifting, which is kind of like multitasking, reasoning, planning, and organization. Executive functions are also really importantly assessed through behavioral observation during the course of the assessment. And oftentimes, collaterals are asked to do rating scales to help better understand executive functioning in daily life, because oftentimes executive functions the problems in executive function may manifest more readily in day-to-day life than they do in the examiner's office in the course of 6 hours. Oftentimes, academic function is assessed, again, depending on the referral question and the presenting concern. Personality and emotional functioning is very often assessed, and the level to which that is evaluated is often, again, dependent on the referral question and the presenting concerns. There may just be a very brief screen of depression and anxiety, or if emotional and behavioral challenges are a significant part of the person's history, we may do more comprehensive assessment of emotional functioning. This can sometimes be challenging with individuals with intellectual and developmental disabilities, because the most common way that we ask about emotional functioning is by asking people to tell us about themselves through rating scales. And oftentimes individuals with intellectual and developmental disabilities may have trouble with reading and understanding the scales, may have trouble with accurately self-assessing and reporting about their own emotional state, particularly over a longer term. So sometimes collaterals are interviewed as part of this process too. And then effort is an integral part of the evaluation. Whoops, I went too fast through that slide. So without engagement and good effort on the part of the individual being evaluated, the results are not meaningful. So a person can sit across the table from me and give me answers, but if I don't feel that that person is really putting forth effort or really attentive or trying, then I'm concerned that the numbers that I have don't tell me much about them. So assessment of effort is done not only through observing behavior, paying attention to the types of responses, the quality of responses, but there are also formal measures of effort that are built in or that are administered separately to better understand that. And a neuropsychological evaluation should include a statement about effort and validity of the results. So does the evaluator feel that these results are meaningful? And if you're reading an evaluation and the examiner says that they have concerns about the validity, then it's important to take all of everything that's said after that with a grain of salt, which sometimes doesn't happen, unfortunately. So in terms of interpreting findings, I talked earlier about use of normative data. So all of the scores from the various tests are all converted using normative data to a standard scale. I'm going to move forward the image to the normal curve here, which is sometimes called the bell curve, which helps us understand kind of average performances or performances that may be below average or above average. So if you're looking at the kind of the top of the bell shape here in the normal curve, you see the numbers 34.13 both to the left and to the right. And scores on tests that fall anywhere between that left bar and the right bar that say 34.13 between them would be average scores. And what we're doing when we use normative data is converting all of the raw scores to standardized scores so that we can kind of put them in our minds on this scale and understand an individual's strengths and weaknesses, as well as understanding an individual's strengths and weaknesses compared to the average population. And that helps us integrate the findings and make sense of the findings so that we can better understand what's happening. So norms allow us to compare standardized scores to each other to identify strengths and weaknesses. They allow us to compare standardized scores to an estimated baseline. So if this is an individual who, for example, has had a new traumatic brain injury, we need to try to understand where they were functioning before the brain injury compared to now. Interpretation, as I said earlier, involves integrating the results with history and with behavioral observations, and involves accounting for effort and emotional factors. I'll move forward too. So I want to talk about findings and recommendations and really about referral questions. So the thing that I hope people take most from this presentation is that the utility of the neuropsychological evaluation can be enhanced by asking specific and appropriate referral questions. So the least useful type of question that ever comes across my desk is, please evaluate. And I get that a lot of times from primary care physicians or neurologists. And it's not only not useful to me, but more importantly, it's not as useful to the individual being seen. A lot of times people come to my office for an evaluation and don't really know why they're there either. So if I haven't been asked a specific question by the referral source, sometimes the person sitting across from me can't help me with that either. And very often, almost always, a person is being referred for a reason. Either the person or people around that individual have questions and concerns and want to know something. And so if you can share what it is that you would like to know, the neuropsychologist can ask the right questions during the interview, can choose the right tests, and can make recommendations to answer those questions. If those questions aren't asked, it's possible that that might be missed. So optimizing the referral, questions such as, why is the report needed? What would you like to know? For my office, we actually have a special form for area agencies for when they make the referral, and there's a couple of empty lines there for people to say that why it is that they're being referred. I love emails or attached forms. If you have more that you want to say, please add it. Who are the consumers of the report? Who asked for this? Who really wants this? What are the needs? Are there referral source special needs? Sometimes teams are looking to make a case for additional supports or additional funding, and helping to understand why it is that the person is here is really crucial. I mean, I may not be able to help with that effort, but at least I understand what the reason is. Understanding timelines, reimbursement, is there litigation? These are all important. So I'll wrap up, and I'll try to, in about 5 minutes, try to wrap up by talking a little bit about what are the types of questions that neuropsychological evaluation can answer. So diagnostic questions are very common. They were more common before we had MRIs and CAT scans, where people could actually look at the brain more clearly and identify whether or not there was evidence of injury to the brain. But they continue to be really relevant in neuropsychology as well, because not all neuropsychological conditions are obvious on a CAT scan or an MRI. So neuropsychology, again, is helpful for identifying whether or not there's objective evidence of cognitive impairment in the context of concerns about cognition. So for example, I not infrequently see individuals who have been served by area agencies for many years, who are aging, and we actually just in this office here before this presentation, we're talking about examples like this, where the individual may be starting to manifest some changes in behavior or in daily functioning, and there's a question about why is this happening, and in some cases the question is this an early dementia? Is that why the person is demonstrating some behavioral changes? So neuropsychological evaluation can be helpful in identifying whether or not there's objective evidence of cognitive changes that might signal the presence of a dementia. It again can help understand the reason for, so we can identify that there are or are not cognitive impairments, but we can also help try to tease out why those cognitive impairments may be present. Perhaps there are some psychological factors that may be playing a role. Maybe there's some medical issues. Maybe there are medication-related problems. And then this in turn can help guide treatment and or cases for support, eligibility, that sort of thing. Neuropsychological assessment is helpful for treatment planning, so helping to understand what the individual's strengths and weaknesses are from a cognitive standpoint. That this can be used to help guide rehabilitation, education, vocational services. So being able to understand what the person does well, what they have challenges with. This can help individuals working with that person understand what accommodations may be necessary, what types of compensatory strategies are best used, If this is someone who is a verbal learner and the team has been putting up images all over the house to help them remember something, that may not be the best way to go about it. If this is an individual who has a lot of trouble with auditory comprehension, and the team is frustrated that this individual is not kind of following through with what's being asked, it may be helpful to understand that auditory comprehension is a challenge and there are other ways that you may need to interact with that person. Evaluation can also help to identify the need for referral to other specialists who can either do additional assessment or support and intervention. In addition, there are some more kind of subspecialty types of purposes for neuropsychological evaluation. Sometimes we're used to help monitor response to medication or other interventions. So we may do pre-post testing for individuals who have an acute event like a stroke or a brain injury. We may be asked to assess recovery over time as people improve and as time passes. In some cases, neuropsychologists are helpful in conducting pre and post evaluations for people who undergo surgery for treatment of seizures or tumors. In many cases, one of the things that neuropsychologists do is help to understand psychological factors that may be contributing to a medical or neuropsychological condition. So again, a thorough assessment of emotional and behavioral functioning, to help understand why it is that the person is demonstrating perhaps behavioral changes, perhaps things that look like cognitive deficits, but may actually reflect another underlying reason. Can also help to recommend treatment approaches. So if this individual is manifesting signs of depression, yet has significant learning and memory impairments, we're going to need to think a little bit more creatively about the type of intervention that we recommend. So traditional talk therapy is not particularly helpful for someone with severe learning and memory difficulties because they may leave the session and not have any retention of what was discussed, and certainly won't be able to use strategies that were described or practiced. And so recommending accommodations and supports that the person might need to help them use those skills, as well as clarifying what types of treatment approaches might be most useful. And then neuropsychologists are also asked, neuropsychologists are also asked to answer questions about real-world functioning. So things like, can this person return to work? If so, what types of accommodations or supports need to be in place? Is this individual safe for driving? Can this person make independent decisions? Do they need a guardian, or is that recommended? Is the individual able to understand and comply with a treatment regimen? Can this person live safely without supports? Those are some examples of some of the real-world types of questions that neuropsychologists can help to answer. So that's all I have. I think we'll open it up to questions.
Perfect time.
Right on time. Yep.
Great. So thank you very much. I'm going to, while we're opening up our Q&A box here, I know we have a few questions from folks on the webinar. I just wonder, while I'm kind of queuing these up, if you could just sort of share, anything that you're aware of that sort of is evolving in the neuropsychology field that folks should be aware of. And I'm thinking in terms of, the emergence of integrative medicine, any sort of, better understanding of how sort of the brain and the body work together that influences how you evaluate folks, or maybe what some of your recommendations are.
Yeah. Well, I think the integrative medicine component is a big one, and I think an understanding of brain and body relationships is also important. And we understand more and more factors such as emotional functioning and how that impacts cognition. Factors such as sleep, appetite, eating, daily activities. Those are all things that I think neuropsychologists are assessing more and more as part of their evaluation, as part of the clinical interview, and trying to understand those components. One of the other factors, not one that you specifically mentioned, but that is coming up more and more, and may in fact overlap with some of the individuals that are being supported through area agencies, is changes in laws around marijuana, medical marijuana. And that actually creates some complications for neuropsychological evaluation because some marijuana can impact cognition. And so I see more and more individuals coming in for evaluation who are using marijuana regularly as medically prescribed, and who are presenting with questions of cognitive difficulties. And so trying to tease that out can be challenging.
Right. Well, that's great. We have a question that came in from one of our attendees who recently referred somebody for a neuropsych eval, and when got the report back, it was listed as a geropsych eval. Is there much of a difference between those two type of evaluations?
So a geropsychologist, I'm not sure if it was a geropsychologist or geropsychiatrist, and that actually matters, but a geropsychiatrist or psychologist would specialize in working with an older adult population, obviously, and may or may not have specialized training in neuropsychological evaluation. My guess is that that individual may have done more of a cognitive screening assessment, which is typically a very short battery of tests. And there's nothing wrong with that. Cognitive screens are used all the time, including by primary care physicians. The problem with cognitive screening is that it's not very sensitive. So we end up with a lot of false negatives. So someone may pass a cognitive screen, but in fact may have some more subtle cognitive difficulties that weren't identified, again, because the measure was not particularly sensitive. Yes, those are different types of evaluation.
And, sort of along those same lines in terms of severity, is it typical for a neuropsych assessment to result in a specific identification of the severity of particular, for example, mild versus moderate versus severe in terms of intellectual disability?
Yes, that is one of the things that we can do. Again, going back to that normal curve and the kind of that bell-shaped curve that I showed earlier, one of the things that we're doing is placing all of the performances along that curve in terms of, and we use descriptors such as average, low average, borderline impaired, mildly impaired, moderately impaired, and severely impaired. And so as you get out to kind of the tail of that curve, we're looking at performances that are much, much weaker than average for that individual's age and education. And so helping to clarify for intellectual disability, we're looking not only at test scores, but also adaptive function, obviously. But that sometimes is part of a referral question, is helping to identify not only whether or not there are deficits, but what the severity is.
Great.
Yep.
Now, do you recommend that people have a neuropsych evaluation as, to establish some sort of a baseline? If there's maybe somebody's has a condition identified that, is likely to become progressive, or at least, sort of, again, kind of snap a line on, and say, here's where we are today, just in case there's going to be any changes down the line, we want to know.
Well,
what the baseline
certainly,
is.
as a neuropsychologist, having a prior evaluation against which to compare results is the best thing you can ask for. And so would I like every person to have a baseline evaluation? Sure. Is that reasonable? No, insurance won't pay for it. It's a lot of time and effort. You may end up with people who actually have no real problems. You end up with false positives. So that's kind of like the recommendation that everybody have a full body MRI scan. Sure, it would be ideal, but how useful is it? So I think, what happens more often, and what I think is probably more reasonable and fully appropriate is if there is any concern, any question about change, or a new onset of a problem, that an early evaluation is very helpful. And in assessing, particularly if there's a question of progression, so is this person developing a dementia, having an initial evaluation and then having that person be able to return a year later, 2 years later, to identify objectively whether there's change is very helpful.
Right. One other thought that I had while you were presenting is, when you're trying to really make the connection between someone's behavior and what's going on in the brain, I imagine at times there's sort of a relief that people feel in getting the information. In other words, okay, it's not my fault, or it's not a result of bad parenting, or, now this makes sense to me, why, Jonathan never follows through on directions. He couldn't understand what was being asked of him.
Yep.
Is that a common experience?
I think so. I mean, I often hear from team members that this has been helpful in really clarifying what's happening for this individual and trying to kind of tease out some of the difficulties. One of the things, again, especially with individuals who are being supported by a treatment team, is that if someone has cognitive challenges and a history of behavioral problems, it's not uncommon for team members to kind of default to the idea that this is behavior, this is intentional, this is deliberate, that he's intentionally not remembering or intentionally not understanding. And certainly, there may be times when that's the case, but I think it's also very helpful at times for people to understand that, well, there are actually some cognitive challenges here that are creating this situation and that are making things more difficult. And if you change the way that you work with this individual, everyone will have a better outcome. So absolutely.
Great, that's great. Well, I think we're just about out of time. I want to sort of remind our audience of a couple of things. One is that we're going to be sending out a survey after the webinar today, and we really, really appreciate your feedback. So please take some time and let us know what you think in terms of today's presentation, other topics that you'd like to see us put together for you. And I just want to give a plug for a couple of other presentations coming up. On December 19th, CSNI is going to host our December webinar on special needs trust with Ann Butenhoff and Judith Baumster, attorneys from Manchester. And January 10th, we'll have a presentation on applied behavior analysis by Leanne Millender from the Institute of Professional Practice. Again, please continue to tune in, and we're happy to provide this content to all of you, and we're hoping that you're finding it helpful. I know I feel really grateful, Dr. Griffin, that you've shared this time with us today. I think the information you presented was incredibly insightful and helpful. And for all of our viewers out there, thanks for tuning in with us today. We look forward to seeing you back on our next webinar.
Thank you.
All right.